Here's some videos that I've completely stolen from Dr. Swaydan. He's published the literature and has explored the idea of these ETVs in patients with a very, very narrow or almost obliterated prepontine cistern. There's a quote from his paper there: diminished or obliterated PPI is not a contraindication to ETV. Personally, I don't think this is where you really want to start your careers, focusing on the hardest possible thing you can technically do with an endoscope. But it does illustrate a couple of really important features that I thought were worth sharing. And so these are videos from his papers showing that even in an MRI scan or patient where you don't think that there's any physical space on the MRI scan between the basilar artery, you can either go on the side or along the dorsum sellae and actually create that interval. And by the end of the case, I think you'll be convinced here that it's a fairly successful endeavor. So here's, sorry, I'm just gonna go back. Here's the video. I'm sorry, it's a little small on the inside here. But their basilar artery is essentially right up against the dorsum sellae here. Just nothing more than a little nudge on the floor of the third, right up against the dorsum sellae here. This takes a little courage to do this. Very, very gentle, just pushing. All of a sudden you can see that a little daylight is created there. Nothing more than, a little safety to know that you're in that space in front of the dorsum sellae. That little dark shadow there gives you that confidence. And once you've got that, placing the balloon in there is completely safe, again, because it's soft and malleable. And so even what looked like really going to be a difficult case, now you can see that's a beautiful stoma, and that's going to be a successful ETV. So not a contraindication, not something for the faint of heart and to start out, but the idea that this child was potentially spared a shunt for the rest of his life is something that's important to recognize and is a powerful thing to watch. And here's another case. I'm going to put a little pause here as well, just so you can appreciate the anatomy here, right? So you can see the apex of the basilar artery right up against the dorsum sellae and the infundibular recess right there. So everything is really packed in nice and close, but off to the side, so the interval between the dorsum sellae and the vasculature is a little bit more defined. And so here you'll see again, find the dorsum, find the bone. That's a hard stop right there. We're feeling against the bone. And then we're just gently probing, gently pushing against the floor and sliding off on the side there. If you go too far lateral, you've got the third nerve complex. So you can't go too far, but as long as you can see that basilar apex there, you slide along the dorsum. Again, I've shown this time and time again, that's going to be a safe interval there. You can see the membrane of Lilliquist blowing it up. And so again, a really, really small interval, but quite a successful result at the end here. Just let it play out for the last 15 seconds so you can see the demonstration here. Nice and pulsatile, clearly through the membranes of Lilliquist. Definitely a small interval. I would say this patient probably has a higher chance of an occlusion from scarring than the previous one, but certainly that's going to be successful and something that can be followed over time.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.